I'm Billy A Caceres. I'm an assistant professor at Columbia University at the School of Nursing in New York City. And my research focuses on social and structural determinants of cardiovascular health among marginalized groups with a focus on sexual and gender minority adults. So the term sexual minority is sort of an umbrella term for a number of individuals who do not identify as exclusively heterosexual. So sexual minorities include people who identify as gay or bisexual or pansexual. And what we know in the literature is that sexual minority individuals experience a number of health disparities, particularly around mental health, substance use, and HIV/AIDS, but very few studies have focused on cardiovascular health in this population. My work seeks to sort of understand the cardiovascular health of this group by specifically looking at social and structural factors that may contribute to disparities in cardiovascular health. And I think it is important because sexual and gender minorities in particular, there's sort of no biological basis for the disparities that we see in these groups. So by understanding the social and structural factors that lead to these disparities, it can help clinicians, politicians, healthcare providers, a number of different groups sort of better understand how to actually decrease or mitigate some of the disparities that exist in these groups. So the study that we conducted is a secondary analysis of data in the United States from the National Health and Nutrition Examination Survey. We used data from the years 2007 to 2016 that included about 12,000 people. About 4% of those individuals identified as sexual minorities, either gay, lesbian, or bisexual. And one of sort of the challenges when we use existing data and we do a secondary data analysis is that you're limited in terms of the variables that are available in the data set. What we decided to do was to examine cardiovascular health disparities between sexual minority and heterosexual adults by controlling for a number of confounders that were available in the data set. Things like that we know that things that influence cardiovascular health, like age, race and ethnicity, education, income. And then we also controlled for some factors related to healthcare utilization, such as whether or not participants had insurance, healthcare insurance, and whether or not they had had a routine health exam in the past 5 years or so, asked in increments of in the last year, in the last 2 years, and so on. And then we also controlled for depressive symptoms, given that there's growing research showing that individuals with a history of depression are more likely to develop cardiovascular disease. So we focused the selection of confounders and controlling for them in our statistical models based on existing research showing their associations with cardiovascular health, as well as sort of compromising with what variables were available in the data set. Cardiovascular health was measured with the American Heart Association's Life's Essential 8, which is their new measure of ideal cardiovascular health. Previously, the American Heart Association in 2010 had developed the Life Simple 7, which included 3 health behaviors: physical activity, diet, and tobacco use, and then 4 health factors, which were body mass index, hypertension, high cholesterol, and diabetes. Life Essential 8, which was just released in 2022, included an 8th component of sleep health, particularly sleep duration, because there's strong evidence over the past 10 or 15 years that sleep duration and sleep health in general are strong predictors of cardiovascular health. And although Life Essential 8 has just been released, so there's not a lot of evidence sort of about its correlation with cardiovascular disease, development of cardiovascular disease or cardiovascular disease mortality. What we do know is Life Simple 7, the previous measure, over the past 12 years, there's been consistent evidence that individuals with worse Life Simple 7 scores are more likely to develop cardiovascular disease, die from cardiovascular disease, as well as develop a number of other chronic conditions, including cancer, dementia, and so on. So what we did was we sort of capitalized on the fact that the National Health and Nutrition Examination Survey includes all 8 measures of cardiovascular health that are included in Life Essential 8 and conducted the first analysis examining sexual identity differences between sexual minority and heterosexual adults. And what we found in our analysis in the data set was that, not surprisingly, gay men, lesbian women, and bisexual women were much more likely to be tobacco users and have higher nicotine exposure than their heterosexual counterparts. And then among bisexual women, we saw that they were more likely to meet criteria for obesity and also had overall worse cardiovascular health scores, indicating that they might be at higher risk for developing cardiovascular disease in the future. And then among gay men, what we found, which is actually pretty consistent with previous work, is that gay men in general had better diet quality and lower risk of diabetes than heterosexual men. And that's sort of consistent with evidence that from our group and others that has come out in the past few years. What I think is important to note is that the analysis that we did only included individuals with no previous history of heart disease or cardiovascular disease. So anybody that had had a stroke or a heart attack or a diagnosis of coronary artery disease was excluded from our analysis. So really what our findings really show is that among individuals with no existing history of heart disease or cardiovascular disease, we found that bisexual women seem to be at higher risk of developing cardiovascular disease in the future. The findings for bisexual women that sort of emerged from this analysis are pretty consistent with previous evidence that they're more likely to meet criteria for obesity and also more likely to smoke than heterosexual women. And although we were unable to truly sort of test some of the social determinants that may drive those disparities in cardiovascular health among bisexual women, we have some ideas about what might be leading to these disparities. And I think it can be broken down into three main reasons. So one, this analysis was in the United States, and data from the United States really indicates that bisexual individuals, particularly bisexual women, are much more likely to live in poverty than heterosexual people. And that may impact their ability to obtain healthcare in a timely manner, particularly around preventive care, which in this sample, really that's what we were interested in, was, and among individuals that don't have heart disease, what is sort of their risk of developing future heart disease risk? And so that's one aspect of it, is sort of higher rates of poverty. The second aspect of it is there is consistent evidence showing that bisexual women and lesbian women are more likely to delay seeking healthcare because of concerns related to costs. So it's also sort of tied into income or an economics of seeking care. But if we know that bisexual women are more likely to delay care, then that means that they may go longer periods of time without being diagnosed with a number of health conditions, such as hypertension or diabetes. And by the time they do get diagnosed, they might be sort of at advanced stages of disease. So that may be one aspect of it. It's sort of these delays in care. So they're not receiving preventive care. And then the sort of prevailing theory for why bisexual individuals in general, but in this case, bisexual women, may have worse health outcomes. Because actually what we found for cardiovascular health has been pretty well documented that bisexual individuals tend to have worse substance use and mental health outcomes compared to heterosexual and gay and lesbian individuals. So the reason why researchers think that that exists is because bisexual individuals are exposed to increased stressors by being a bisexual individual. And these stressors are called in the literature minority stressors. So all minoritized or marginalized individuals, like sexual minority people, experience greater stress than the general population. They have to worry about things like coming out to their family. They have to worry about potentially being rejected because of their sexual orientation. But for many bisexual individuals, they may have even increased stress related to both potentially being rejected or experiencing discrimination from heterosexual individuals, as well as potentially experiencing discrimination from gay and lesbian individuals. So this sort of puts them in the situation where they're at increased risk for experiencing stress, which can then lead to a number of different negative health outcomes, and in this case, potentially cardiovascular disease. So these findings have important implications for clinical practice. I think the main sort of takeaway for our team is that healthcare providers, so physicians, nurses, and other healthcare providers, need to really understand some of the health disparities that exist among sexual minority individuals and understand some of the factors that lead to those disparities in cardiovascular health in particular. I think what these findings also show is that there is a need for targeted efforts, both clinical and public health campaigns or public health interventions to reduce tobacco use among gay, lesbian, gay men, lesbian women, and bisexual women. And then in particular for bisexual women, there's a need to address their overall increased cardiovascular risk, as well as to address their higher risk for obesity. And I think that providing clinicians with that information can help them sort of tailor their education during preventive visits, and also tailor some of the approaches that they might take in caring for sexual minority individuals. I think another sort of really important takeaway in terms of clinical implications is the need for healthcare providers to create environments that are welcoming for sexual minority individuals, having open conversations with their patients about some of the health disparities that have been documented among sexual minority individuals, because I think it sort of will do a lot to sort of increase patient-provider communication. As indicated earlier, lesbian and bisexual women in particular are more likely to delay care. And part of that is related to concerns related to costs, but we also know that many sexual minority individuals have experienced or report that they have experienced discrimination in healthcare settings. So whatever we can do to make sexual minority individuals more comfortable in seeking and engaging in their healthcare with the healthcare system, I think will be a really big improvement in terms of compared to what we're doing now. There are a number of policy or advocacy implications for the research findings of our paper. I think because the sample was from the United States, a lot of the implications sort of are more focused on the United States. But from a policy perspective, we know that things like structural factors like structural racism and structural sexism are associated with negative health outcomes. And there's a robust body of evidence that shows that structural racism is associated with higher cardiovascular risk and cardiovascular disease mortality. But we don't know that much about how structural factors influence cardiovascular health and really the overall health of sexual minority individuals. So I think from that perspective, we need additional research to understand how policies such as discrimination laws that don't protect sexual minority individuals from discrimination, or hate crime statutes that don't include specifically criminalization of hate crimes against sexual minority individuals. We don't really understand how the lack of those policies or the presence of those policies might influence the cardiovascular health of sexual minority individuals. So from that perspective, I think we need more research around these sort of policy level factors that can influence the cardiovascular health of sexual minority individuals to help us better understand how we can use that research to inform policy to promote their cardiovascular health. From another perspective, we know that there is a need for additional research around the heart disease and chronic disease risk in general among sexual minority individuals. So they're really, from a policy perspective, we need more funding around research and even public health programs around efforts to reduce cardiovascular disease risk among sexual minority individuals, and tobacco use being sort of a very attainable goal in terms of reducing tobacco use among this population, which seems to be sort of the main risk factor for heart disease that is found across all sexual minority individuals. So I think based on our findings, I think that that's sort of really the takeaway, is that we need more research on how policy influences heart disease risk to better inform among sexual minority individuals, to better inform efforts to improve their cardiovascular health. And then we also need increased funding to sort of understand, to sort of promote research around this area.